a Master of Science in Nursing from the University of Colorado at Colorado Springs. And she's a clinical nurse specialist with certification in public and community health. Linda served as the co-chair of two recent guideline development committees for health teamworks, the Preconception and Interconception Care Guideline and the Contraception Guideline. And we're very grateful to Linda for that work with Health Teamworks and those guidelines that are proving to be very, very popular guidelines, and also for her presentation today. So now I'll turn it over to Linda Archer.
Oh, thanks, Carolyn. And thank you for arranging your schedule to join us for this webcast. The purpose of the webcast is to present findings from a data analysis that was conducted by the Colorado Department of Public Health and Environment. We'd also like to offer up some recommendations to improve preconception health and to share with you some resources to help you do that. Staff members from the Colorado Department of Public Health and Environment Women's Health Unit, the Epidemiology, Planning, and Evaluation Branch, and the Health Statistics section worked on this analysis that was published as a Health Watch number 78. The Health Watch article was written by me, Mandy Bukulski, Sue Ricketts, and Q View, and I'd like to thank them for their knowledge, skill, and guidance in gathering the data and presenting the findings in a practical and understandable format. We can, after the webcast is over, we can send you a PDF copy of the Health Watch publication as well as the slides from this presentation. I'd also like to extend special thanks to Lori Consola, Deputy Regional Health Administrator with the Department of Health and Human Services Region 8. She arranged funding for the production of this webcast, and we appreciate that very much. I'd also like to thank Thea Caruth and Emily Gingrich with Health Teamworks for facilitating and producing this event. These are the objectives for this webcast. I'll let you read those. I won't read them to you, but I think it's important that we start out with a solid understanding of what preconception health is. Oftentimes, we associate the term preconception with the time period in life just before a woman conceives a pregnancy. However, preconception is actually the time period across the lifespan from menarche to menopause, when girls and women are not pregnant, including the time spans between pregnancies. Preconception care is a bundle of 12 to 14 interventions that, if implemented when a woman is not pregnant, can improve a woman's health, but also have the potential to improve the health of her future offspring. Preconception care is not a single health care encounter where providers instruct women about health practices immediately before pregnancy. Preconception care is a paradigm of health care providing primary prevention interventions by regularly addressing issues with every woman from menarche to menopause at every visit who might someday conceive regardless of pregnancy intention. So, why do we need preconception care? And why should we be on board with this paradigm of health care? And why should we regularly address preconception issues with every woman who might conceive at some point in the future? Well, in Colorado, 39% of births result from pregnancies that are unplanned, and thousands of women are at risk for unintended pregnancy. According to the authors of the book titled The Best Intentions, Unintended Pregnancies and Well-Being of Children and Families, unplanned or mistimed pregnancies are associated with late entry into prenatal care, low birth weight, elective abortions, child abuse, and behavioral problems in children. In addition, if a woman does become pregnant, most fetal organs and placental vessels are formed by the 12th week after conception, and many interventions to prevent poor birth outcomes come too late in pregnancy to have an impact. Scientific evidence indicates that the improvement of a woman's health before pregnancy can improve pregnancy outcomes for both mother and child. Protective behaviors like taking folic acid improve health, while risk behaviors such as smoking and drinking alcohol diminish health status. Reducing risk factors and promoting protective factors, regardless of pregnancy intention, is critical for the health of women of reproductive age and any potential children they may have in the future. Medical providers and public health professionals have a role in addressing these risk and protective factors before pregnancy occurs. There are several very good reports that have been published in the past using data from the Pregnancy Risk Assessment Monitoring System, or also known as PRAMS. PRAMS surveys women in the postpartum period, but for this analysis, we wanted to look at data for all women, not specifically in the postpartum period. So we gathered our data from the Colorado Behavioral Risk Factor Surveillance System, also known as BRFSS. I want to give you a little background about the BRFSS. The Colorado Behavioral Risk Factor Surveillance System is a statewide telephone survey on health conducted by random digit dialing of adults 18 years and older living in households with a landline telephone. The Survey Research Unit of the Colorado Department of Public Health and Environment conducts the survey annually in collaboration with the Centers for Disease Control and Prevention. This presentation describes preconception risk and protective factors among Colorado women ages 18 to 44 years using data gathered from BRFSS for the years 2004 through 2006. A total of 4,250 women were included in our analysis. So the risk factors that we looked at include smoking, being overweight or obese, poor mental health, and alcohol use. And I want to explain how these risk factors are defined. A woman who smoked at least 100 cigarettes in a lifetime and smoked every day or some days was designated as a smoker. Women with a body mass index of 25 or greater were considered overweight or obese. Poor mental health was defined as one's mental health being not good on at least one occasion in the past month. And the definition of alcohol use included any woman who drank any type and amount of alcoholic beverage in the last month. Binge drinking definitions were not consistent from year to year between 2004 and 2006. So binge drinking was defined as 4 or more drinks in one setting in some years, or 5 or more drinks in one setting in other years. Protective factors include eating well, taking folic acid, and exercising. Eating well consists of eating 5 or more servings of fruits and vegetables per day. Taking folic acid was defined as taking a daily vitamin containing 400 micrograms of folic acid. And exercising included women who either exercised moderately for at least 30 minutes per day, 5 times a week, or who exercised vigorously for 20 minutes per day, 3 times a week. So a descriptive analysis was conducted to identify all women ages 18 through 44 years. We also analyzed differences between age groups and grouped them into 18 to 29 years and 30 to 44 years. We also analyzed data by ethnicity, and we analyzed it by Hispanic or non-Hispanic. We had a question earlier about why we didn't also include African American. The reason we did not is because for the years that we were studying the data, we did not have enough survey responses from African American women to appropriately analyze that data and compare it to other women. We also analyzed data by when a child was desired. The desire for a child was determined by identifying respondents who indicated they wanted to have a child now or sometime in the future. Those responses were then grouped according to women who wanted to have a child within 2 years and those who wished to wait 2 or more years from the time of the survey. All the data were analyzed using SAS version 9.2. Okay, so this graph shows the percentage of all women ages 18 through 44 years who smoke, who are overweight or obese, who have poor mental health, who use alcohol or binge drink. To provide a comparison with these percentages, I queried the BRFSS data for all adults, both men and women. The results were very similar with the exception of poor mental health, which for both men and women was only 22%, and for our analysis it was 45%. All of these percentages are worrisome, but alcohol use is especially concerning. This graph illustrates the prevalence of protective factors that, when present, may enhance women's health and potentially improve birth outcomes. Again, for comparison, BRFSS percentage for all adults, men and women, were very similar, with the exception of exercise, and that percentage for both men and women was 83% as opposed to 57% in our data analysis. This graph shows the percentages of risk factors comparing Hispanic and non-Hispanic women. The yellow bars are percentages of Hispanic women, and the orange bars are for non-Hispanic women. And as you can see, Latinas are significantly less likely than non-Hispanic women to be smokers. They're less likely to report poor mental health. They are a lot less likely to use alcohol or to binge drink. Hispanic women are significantly more likely to be overweight or obese compared to non-Hispanic women. And I want to point out on this graph, the vertical black lines are representative of the 95% confidence intervals. And I just wanted to point that out so you know what those are. The prevalence of protective factors is significantly lower among Hispanic women, represented by the yellow bars, compared to non-Hispanic women, represented by the orange bars. 19% of Hispanic women report eating 5 or more servings of fruits and vegetables daily, compared to 30% of non-Hispanic women. 25% of Hispanic women take folic acid, compared to 46% of non-Hispanic women. And just under half of Hispanic women report moderate or vigorous physical activity, compared to 59% of non-Hispanic women. This graph illustrates the prevalence of risk and protective factors of women desiring a child within 2 years of the survey, represented by the yellow bars, and those who wish to wait 2 or more years, is indicated by the orange bars. This data reveals health behaviors of women who want to have a child sooner are no different from the health behaviors of women who desire a child later. Overall, women who desire a child in the near future are just as likely to smoke, just as likely to be overweight or obese, just as likely to report poor mental health, drink alcohol, and binge drink as women who want to wait at least 2 years before having a child. In addition, women are not improving their health by eating well, by taking a daily multivitamin, and by regularly exercising either moderately or vigorously. So as much as some of us love data, we have to remember that the numbers represent human lives, and that's the most important thing. These findings highlight the importance of preconception health and its clear message that women of reproductive age should minimize risk factors and maximize protective factors before planning pregnancy or before an unplanned pregnancy occurs. In doing so, they will improve their own health and contribute to the health of future generations. So the bottom line is that providers and public health professionals can encourage women to modify risk factors and support protective factors regardless of pregnancy intention. Health TeamWorks, formerly known as the Colorado Clinical Guidelines Collaborative, developed several evidence-based clinical practice guidelines to help us address risk factors. All of the clinical guidelines that I refer to during this presentation can be accessed on the Health TeamWorks webpage at www.healthteamworks.org/guidelines. Screening guidelines can be incorporated into routine office visits. The time that you spend counseling women and screening can be billed as an additional service using an E&M code in addition to the annual visit code. So the additional time spent will usually be covered by insurance payments. And somebody mentioned on the first call that providers will need to bill with a modifier 25 on the well woman exam. Many of us who work in state and local public health departments can also benefit from knowing the content of these clinical guidelines. And we can also develop and evaluate population-based projects that reduce risk factors and promote protective factors. In some instances, policy change and advocacy might be the best role for public health professionals. And some examples of policy changes that can help with preconception health are things like the Clean Indoor Air Act and the tobacco tax, which have helped to lower our smoking rates for everybody, men, women, both in Colorado. So one recommendation is to incorporate smoking cessation strategies supported by clinical evidence into routine health care visits. We all know that smoking among women continues to be a major public health concern in Colorado. Smoking cessation before pregnancy improves health and reduces the risk for preterm birth and low birth weight. Healthcare providers and public health professionals who provide direct patient care can use the 5 A's approach to counsel patients about quitting smoking. Health TeamWorks guideline for tobacco cessation and secondhand smoke exposure explains the 5 A's approach in great detail. I'm going to just provide you with the meat and potatoes of that guideline, and it looks something like this. Ask every patient at every encounter if they currently smoke. Advise every tobacco user to quit smoking with clear, strong, personalized health messages about the benefits of quitting. Assess the willingness of your patient to make a quit attempt within the next 30 days and set specific quit goals to address barriers such as weight gain. To assist your patients, you can refer them to the Colorado Quit line at 1-800-QUIT-NOW and provide positive practical behavioral coaching as part of a quit plan. If it's applicable, you can recommend tailored pharmacotherapy such as Chantix, Zyban, a nicotine patch, nicotine gum, and lozenges. And then schedule a follow-up contact within the first week after the quit date and a second follow-up contact within the first month. Treat smoking like you would treat an illness. In September of 2009, the Healthcare Policy and Financing Department expanded the Medicaid benefit for smoking cessation. So now patients can have up to 2 90-day drug therapy treatments each year. The copay for generic medications is only $1, and the copay for brand name medications is only $3 for Medicaid patients. Recommendation 2 is to regularly measure and document body mass index and offer specific strategies to improve patient nutrition and physical activity levels. We hear every day that obesity is on the increase in the United States, and we know that it causes numerous health problems. But I'm going to reel it in a little bit and say something about the effects of obesity on pregnancy. An analysis of Colorado birth certificate data found that women who are overweight, obese, or morbidly obese have an increased risk for gestational diabetes, gestational hypertension, induced labor, cesarean section delivery, and large for gestational age infants. And women who enter pregnancy overweight give birth to children who have an increased risk of obesity during their preschool years. Hispanic and older women, according to our analysis, are significantly more likely to be overweight or obese. Health TeamWorks has available a guideline for adult obesity that again uses the 5 A's counseling approach. In addition, the guideline lists available resources so that providers have options for patient treatment plans. The Adult Obesity Clinical Guideline can be accessed on the Health TeamWorks webpage, and I'll say it again, www.healthteamworks.org/guidelines. The 5 A's when counseling obesity patients look something like this. Ask permission to sensitively approach weight and how it impacts health. Is your weight a health concern? Ask them. How do you feel about your weight? You can advise your patients that excess weight can negatively impact your health and the health of potential children. You can assess your patient's readiness to change. You can assess their body mass index, their diet, their physical activity patterns, and their health risks. And also assess their cultural, environmental, and psychological settings and barriers. And you can also assist them by negotiating a realistic step towards weight loss or maintenance and arrange referral and or follow-up to achieve and maintain a healthy weight. The U.S. Department of Health and Human Services recently came out with new dietary guidelines, and those can be found at dietaryguidelines.gov. A few simple steps that consumers can take to begin to make lifestyle changes are to avoid oversized portions, make half of your plate fruits and vegetables, switch to fat-free or 1% low-fat milk, and drink water instead of sugary drinks. There are several smartphone applications and iPhone applications, internet sites that are available free that consumers can use to track points or calories. And a lot of the studies that I've read indicate that the food diary approach is very effective. And I just wanted to say, because oftentimes I've heard providers joke around and say, well, you can lead a horse to water, but you can't make him drink. And that is true, but my view of it is you can lead a horse to water and you can't make him drink, but if they die of dehydration, you've done everything you can and it's not your fault. So keep that in mind. We can at least educate folks about these things. Okay, so recommendation number 3 is to discourage alcohol use among women who are desiring pregnancy, with particular attention to young women ages 18 to 29 years old. There is no safe amount of alcohol intake during pregnancy. Any alcohol intake during pregnancy increases a woman's risk for having an infant born with fetal alcohol spectrum disorder, which can consist of facial deformity, hearing and vision problems, growth deficits, and developmental delay. Effects from alcohol exposure can occur before a woman even knows that she's pregnant. And women who drink alcohol can be prescribed an effective birth control method and to prevent unplanned pregnancy. Women who drink any amount of alcohol and are sexually active should be prescribed an effective method of birth control. Health TeamWorks has developed a clinical guideline for contraception to help providers counsel women and prescribe the best birth control method for each patient. The contraception guideline can be very helpful, especially for primary care providers who don't routinely see patients for birth control needs. Also, the Health TeamWorks and SBIRT Colorado developed a clinical guideline to assess patients for risky use of alcohol and other drugs. Brief motivational conversations with patients can promote significant lasting reductions in risky use of alcohol and other drugs. The guideline for alcohol and substance use screening offers very detailed interventions that providers can implement for patients who screen positive for risk drinking and substance use. Recommendation number 4 is to incorporate mental health promotion, screening, and referral into clinical visits and public health prevention efforts. Increased reports of poor mental health indicate that there are gaps in consumer knowledge about what mental health is, when they should seek professional help, and what the treatment options are. It also carries a negative stigma with the label. Mental health conditions are associated with increased risk of postpartum depression, increased rates of substance abuse, lower use of prenatal care, and adverse infant and family outcomes. The Health TeamWorks Preconception and Interconception Guideline provides basic counseling recommendations for depression screening and includes information about contraindicated medications for women who are either desiring pregnancy or women who are not using effective birth control. The Health TeamWorks Depression Guideline is a comprehensive guideline that specifically addresses screening, depression diagnosis, treatment, and monitoring. Recommendation number 5, discuss the role of fruit and vegetable intake in maintaining a healthy diet. Eating at least 5 servings of fruits and vegetables every day helps reduce the risk of some cancers, heart disease, and many other chronic conditions. Chronic conditions affect women's health during pregnancy and can have a lifetime impact on infants. Colorado Latina women are less likely than non-Latinas to eat 5 fruits and vegetables each day. Practical advice from several nutrition sources suggests that, again, we fill half of our dinner plates with fruits and vegetables and improve our diets to include at least 5 colors of food. One positive policy change, public health policy change, was the addition of fresh fruits and vegetables in the Women, Infants, and Children, or the WIC list of approved foods. I mentioned earlier that the U.S. Department of Health and Human Services recently came out with new dietary guidelines. Again, those guidelines can be found at dietaryguidelines.gov. When you get a chance, you can take a look at these, and if time permits during your office visits, just insert a few positive dietary recommendations to your clients during their visit. Another recommendation is to advise all women of reproductive age to take a daily multivitamin containing 400 micrograms of folic acid. Taking folic acid before and during pregnancy can prevent from 50 to 70% of neural tube defects. Neural tube defects do occur in a developing embryo within the first 12 weeks before a woman might even know that she's pregnant. So this is very important. The Centers for Disease Control and Prevention reports that Latinas in the United States consume the least amount of folic acid and have the least knowledge about folic acid. This finding was also observed in Colorado, where in our analysis only 25% of Hispanic women reported taking a daily multivitamin compared to 50% of non-Hispanic women. From a public health perspective, there are some states who have developed folic acid campaigns to increase awareness of the importance of a daily multivitamin. They secured grant funding to purchase low-cost vitamins and give them out during WIC visits, at sites that issue marriage licenses and bridal fairs, bridal shops where women would go to buy their dresses and such. And one community partnered with all the pharmacists in their area to provide vitamins to women who were filling prescriptions. That campaign started out as just for women who were filling birth control prescriptions, but when it was pointed out that they were somewhat preaching to the choir because the women were coming in for birth control, they decided to extend it to any woman between the age of 18 through 44 who came in to fill a prescription. Recommendation number 7 is to promote exercise and address barriers to reduce poor health outcomes associated with inactivity. Moderate exercise reduces the risk for heart disease, stroke, breast cancer, colon cancer, diabetes, high blood pressure, and obesity. Exercise is considered a protective factor with benefits that can improve the overall physical and mental wellness of women before pregnancy. Although 1 in 2 Colorado women of reproductive age reported the recommended level of exercise, Hispanic women were less likely to exercise compared to their non-Hispanic peers. Major barriers to increasing physical activity are time, access to convenient exercise facilities, and safe environments in which to be active. And I think those 3 things would require activities that affect the built environment in which people live, work, and play. The recommendation for exercise is 30 minutes of moderate exercise daily for 5 days, or 20 minutes of vigorous exercise per day for 3 days per week. And the time period can be divided into increments. So if a woman wanted to divide that 30 minutes into 3 10-minute sessions of moderate exercise, brisk walking, for example, that's fine to do too. We also need to consider that things like, in addition to brisk walking, things like house cleaning and gardening and lawn work also constitute exercise. So we can encourage women by letting them know these things. There's also a couple of things, the active Wii games and Dance Dance Revolution, which young women have indicated that they really enjoy. And if you enjoy exercising, then you're more apt to do it every day. The next recommendation is to discuss reproductive goals with women and men to promote individual responsibility across the lifespan. The Centers for Disease Control recommend that each woman, man, and couple have a reproductive life plan. The plan sets personal goals related to reproductive decisions. Reproductive life plans provide women and men an opportunity to consider health before conception. The Colorado Department of Public Health and Environment is developing and evaluating a life plan booklet designed to educate and help women set life goals, including plans for having children in the future. And it helps women also to consider preconception health factors, even if they do not desire pregnancies in the future. For Colorado healthcare providers, Healthy Women, Healthy Babies, and Health Teamworks developed a preconception and interconception clinical guideline to promote preconception health during every office visit. I referred to that a little bit earlier. This guideline does include all of the preconception concepts and interventions, and offers some excellent guidance to providers who use it. And it can be found on the Health Teamworks website. So the reproductive life plan can be something as simple as a conversation between the patient and a provider. Provider asking men and women if they ever want to have children, when they want to have them, how many children they want to have, how far apart they want to have kids, and also inquire as to how the provider can help the patient attain the goals that they've set. In addition, providers are well poised to help patients achieve their reproductive goals by discussing appropriate effective birth control methods if children aren't currently desired, or promoting preconception health in earnest if children are desired in the near future. So the information presented today indicates that the health of women of reproductive age is not optimal, and that the health of women who desire a child in the near future is no better than that of women who want to delay having a child. Whether pregnancies are planned or unplanned, the health of the mother impacts the health of the child. Improving preconception health requires changes in knowledge, attitudes, and behaviors of individuals, families, and communities and institutions. Incorporating components of preconception health into existing public health programs can help women modify risk factors and promote protective factors. By encouraging healthy behaviors before pregnancy, prevention experts have the opportunity to help women attain optimal health over a lifetime and across generations. So now we're going to unmute the phones so that you can ask questions. You can either ask them on the phone.
All attendees have been unmuted. You will now rejoin the meeting.
You can either ask them over the phone or you can type them into the chat feature of.
And we have a couple already.
Oh, do we?
First question, in what community were the vitamins distributed? Who funded the grant?
That project was actually not in Colorado. It was in another state. And so I don't know the exact community, and I don't know who funded the grant. But I can certainly look that up and get that answer for you. It may take me a little while. So I don't know who asked that question, but if you want to email me the question directly, I can get the answer for you. I just don't know it right off the top of my head right now. Sorry.
All right, and the next question, can you get the analysis for certain cities, Denver or Aurora, where there might be enough African American women to analyze?
Well, there is, if you go to the CDPHE website and you look under the health statistics section, they have like BRFSS, a query function where you could query that data for your specific county. I don't think you could go down and drill down as far as Aurora or specific, what we would call neighborhoods, but you can certainly do it by county. And you can do it that way. We were doing all of Colorado women. So if we couldn't find enough African American responses in the whole entire state to make it, to make our analysis accurate and rigorous, I'm not sure that there would be enough in those areas to do it either. But you can certainly query from the CDPHE Health Statistics website BRFSS data on a county level.
Other questions from the phone?
One question about the billing codes for preconception care. Do you have those billing codes posted with or a link to them from the preconception clinical guidelines that are posted? I'm just wondering how easy it is for physicians to pick up on that information.
No, we don't
or
have
provide?
them. We don't have them on the preconception guideline. And I think it has to be done in a well-woman context, and it might have to be piecemeal. So if you had a appointment with a woman and you just did, say, folic acid or multivitamin counseling, it would have to attach onto just time spent with that 25 indicated. Is that what they call it?
Modifier?
Modifier. I'm sorry. And bill it that way. It's not like there's no billing code for preconception care and all of those 12 to 14 interventions listed and codable.
I just wondered how easy it was for physicians to find that information when they're perhaps looking at the preconception clinical guidelines. They knew they weren't on it, but so I was just trying to think through how we could help the care providers to, pick up on that information and
Right.
know that they can code for it. So that was just my thought.
Yeah, Healthy Women, Healthy Baby is an organization here in Colorado, and they have a preconception care work group. And that work group works to solve problems just like this. They actually developed the preconception guidelines, and I think the next step was to do some rapid improvement activities in private practice that would address these issues in terms of, what staff can do what and what they can bill for. And then to look at what barriers they encountered and then go from there to find out how, if there are any codes that exist specific to preconception, and if not, how can they work around that for billing purposes, including working with health plans.
This is Carolyn from Health Teamworks, and I would just like to mention, building on what Linda just said, is that we are going to be offering free trainings around the state starting in the second quarter of 2011 on a training called Linking Health Issues in Women that will focus on the preconception guideline and some of these risk areas, especially around alcohol and tobacco use. And we always try to address barriers and provide tools and information that make things like billing and reimbursement easier. So I will make sure to make a note that when we start to offer those trainings, we consider how to create a supplement, then post it on our website perhaps, and distribute it to clinics around this issue of reimbursement, because it comes up on several of these areas. The tobacco cessation, the expert screening for alcohol and other drug use, and then this preconception type of women's care. So, and if you're interested in these trainings, please contact us at Health Teamworks. You can find out how to reach us through our website and let us know that you'd like a training. We offer trainings to primary care clinics, to women's health clinics, to public health departments, and we'd be very delighted to come out and offer a free training between the second quarter of 2011 and September of 2011.
Perfect. Thank you.
Any other questions on the phone? So we want to thank you all again for participating today, and you see Linda's email there on the screen, so you can email specific questions, and also feel free to contact us at Health Teamworks. Please use our guidelines, and please let us know what additional information and materials you need to help you deliver evidence-based care to your patients. And thank you again. Have a great weekend.
Thank you.